All right, so the topic we're going to focus on for endocrine today is going to be hyperthyroid versus hypothyroid, which is definitely pretty important for the pants, and it's one of the more important topics in endocrine. So let's just do a quick review of the actual axis, the hypothalamic pituitary thyroid axis, which is something that you should just have a general understanding about to help you understand some of the pathologies within this. So the hypothalamus produces something called TRH, which is thyrotropin releasing hormone. TRH directly stimulates the anterior pituitary to produce both TSH, which is thyroid stimulating hormone, and prolactin, which is less important for the lecture we're going over today, but still important to know. TSH is what finally regulates the amount of thyroid hormone from the thyroid gland, and it activates the thyroid to produce T4. And T4 is converted into the active form of thyroid hormone by the peripheral tissues in the body, like the liver. So that's the pathway it follows. This is just a little diagram so you can actually see what's going on here to better visualize. And of course, the amount of thyroid hormone produced in the body has a negative feedback loop on both the pituitary and the hypothalamus. So you can see that here in the diagram. So let's move on to the most common cause of hypothyroidism in the US, and that's Hashimoto thyroiditis. It's most prevalent, you'll see it most commonly in women 30 to 50 years of age. And as far as the patho, it's an autoimmune destruction of the thyroid cells by a couple different things, both the anti-thyroglobulin antibodies and the anti-thyroid peroxidase, which is also known as your TPO antibodies. So as far as the presentation, what you need to be thinking about is the fact that think about thyroid, it obviously controls your metabolism. So if you don't have enough thyroid hormone because the thyroid cells are being destroyed, you're going to have a decreased metabolic state, which helps you remember the patient presentation. So decreased metabolic state, you're going to have weight gain because your metabolism is slowing down. You may have cold intolerance because the higher your metabolism, the hotter, the more the body heats up. So in this case, it's low. So you have cold intolerance. These people are always going to be cold. Dry skin is something else you can see. Hoarseness you may see because they may develop a goiter. You want to ask them about trouble swallowing and things like that. And then another one you may see as well is constipation, because again the metabolism is decreasing, so the rate of peristalsis in the bowel is decreasing as well. So on physical exam, there's a couple things you may see: bradycardia, again decreased metabolism, slower heart rate, and then something that's very important is decreased deep tendon reflexes. And this is something that you may see in real life. You'll probably see it on your OSCEs if you have a patient presenting with this, and it's going to be most prominent in the Achilles tendon. So that's where you want to test for it if you have a patient you suspect of Hashimoto thyroiditis. And the reason behind this is the calcium ATPase activity of the fast twitch muscle fibers in the body are decreased in hypothyroid because of the decrease of this thyroid hormone, and that translate into decreased relaxation of the muscle fiber. So when you actually hit somebody with a reflex hammer on the Achilles tendon, the reflex will be pretty normal, but when it comes back to the relaxation, when the foot's actually relaxing back, it's going to be very slow. It'll be much slower than in a normal person. Some other things you may see is a loss of the outer third of the eyebrows, which I have a picture here. You can take a look at that, what that looks like. So you'll see that sometimes in hypothyroid patients. As far as diagnosing these patients, the thing you need to remember is the main thing to diagnose is going to be their TSH. You want to get that in all thyroid patients, and when you're suspecting anything going on with the thyroid, and that's a good screening test. So the patients with Hashimoto's are actually going to present with an increased TSH. Now the TSH is going to be increased because if we remember, it's a negative feedback loop from the thyroid hormone. So if you have a very small amount of thyroid hormone in the body because the thyroid isn't producing enough because of the destruction, the pituitary is going to respond to this, seeing that low free T4 in the body and free T3 by increasing the TSH, trying to ramp it up to tell the thyroid, hey, produce more thyroid hormone. You don't have enough. Of course, that's not going to work because the thyroid isn't working the way it should. So you're going to see an increased TSH, the body's trying to respond, as well as a decreased free T4 or decreased free T3. Sometimes you'll see a combination here, and sometimes even an early disease, sometimes it may be normal as well. So that's something to just remember. And then when you're first diagnosing these patients, you want to get their antibodies so you can actually specify which the cause is. And in Hashimoto, you're going to see either positive anti-thyroid peroxidase or something called anti-thyroglobulin antibodies. If you want to do a radioactive uptake scan, what they're going to show is going to be a diffused, decreased iodine uptake on the actual scan. And then a biopsy, which again, you're not going to use very often at all, but if you did, it's going to show something called Hürthle cells, which is one of those names you should know for the boards. And what a Hürthle cell is, it's enlarged epithelial cells with eosinophilic granular cytoplasm. So just remember Hürthle cells. I think that's one of those names you should remember that may come up in an exam. It's not so important in real life, but you should know for that. Treatment's very easy. It's levothyroxine. Brand name is Synthroid. This is a synthetic form of T4. You're going to monitor this, which is important, at 6-week intervals. That gives the body enough time to titrate to the dose that you're giving them. Normally, you're going to start pretty low, especially in elderly patients with cardiovascular disease and things like that. You'll start around 25 micrograms. For healthier, younger patients, you're normally titrating it. You start off at, I think it's about 1.6 microgram per kilo in that level, and then you slowly titrate up based off of the TSH. So one really important thing that you should know, you're going to see this in your pharm exams, you're going to see this in clinical medicine, is that these patients cannot take anything else with the Synthroid. Levothyroxine Synthroid is very dependent upon the acidic environment of the stomach. So these patients cannot take PPIs within 4 hours. They can't eat anything for at least 30, but ideally 60 minutes after taking the med. Iron and calcium have to be at least 4 hours apart as well. So that's something that's really important with this. And you should definitely remember that because it's important for real life. It's important for the exams. And then remember too, if you give too much of this, if you overshoot and they have too much thyroid hormone, you can actually cause osteoporosis, cardiovascular events. So again, this is important in the elderly population to start off real slow and kind of titrate very slowly up until you get them into that good range. You don't want to give them too much. And then of course there's other medications besides levothyroxine. There's something called MP thyroid, Armour thyroid. These are more known as the natural thyroid hormones because they're not made synthetically. Armour thyroid is actually from a slaughterhouse that had all of these thyroids from pigs, and they didn't have anything to do with them, so they actually grinded them up and sold them as a medication, and that has T3 and T4 in it. And some people feel it's it's a more natural form, I suppose. That's what a lot of people think, and that it works a little bit better. Just something to know for clinicals, that you may see Armour thyroid and what that is compared to Synthroid. So the next one you should definitely know for your boards, and this is the opposite end of the spectrum, that's Graves' disease, and this is the most common cause of hyperthyroidism in the US. So the patho, again, is another autoimmune process, but in this case, instead of the antibodies attacking and destroying the thyroid, what they're doing is they're actually activating the TSH receptors. So they're they're hitting these TSH receptors and they're making them produce more thyroid hormone. So they're actually activating the thyroid gland and making it pump out all this excess thyroid hormone. There's a couple ways that these patients are going to present. Again, remember, increased thyroid hormone, increased metabolism, and it'll lead you to the presentation. So they may have palpitations, their heart's going to be beating fast, different arrhythmias. They may have weight loss, high metabolism, heat intolerance. Again, the opposite here, because the metabolism's up, they're going to be very hot, sweating. They may have moist skin. AFib is something that we see in Graves' disease patients. And if you remember the mnemonic PIRATES for the causes of AFib, the T in PIRATES stands for thyroid or thyrotoxicosis for Graves' disease. So remember that. And there's also something called Graves' ophthalmopathy, which is going to be a patient presenting with proptosis, exophthalmos, lid lag. And this is a good picture. You can see what this looks like in real life. This is an exaggerated case, but this is definitely how a patient may present. And what this is caused from is the same antibodies that are hitting that thyroid hormone and activating those TSH receptors are also attracted to the connective tissues and the muscles of the eye. And when they attack these areas, they actually activate fibroblasts. So you're going to have this thickening behind the eye wall, which is going to cause exophthalmos, proptosis, all these different symptoms of the eyes. And that's important to remember for the exam and real life, of course, as well. So another thing that you'll see as well, again, because of the antibody production and the it's also attracted to the lower legs as well. And this is something called pretibial myxedema. They're going to have these red-brown rashes on the lower legs with non-pitting edema. So remember that too. And this is because the antibodies are binding and stimulating fibroblasts in the lower leg, and it's increasing something called glycosam aminoglycan production. So remember that too. Physical exam, a couple things you should know is that they may have a goiter, they may have an enlarged non-tender thyroid. Again, remember it's important to differentiate between painful and non-painful, because there's different causes that cause painful. And in this case, it's going to be non-tender, and they may have a thyroid bruit, which is very difficult to distinguish. It's hard to hear a lot of times, and it's not that common, but you may hear it on an exam, and if you're actually listening and auscultating in that area, you may hear a very small bruit that can be caused from this as well. So the diagnosis is pretty straightforward. Remember what we talked about with Hashimoto, you're just going to be the opposite way. Again, you have all of this increased T4 and T3, so the body's decreasing your TSH, telling the thyroid to slow down, that it doesn't need to produce as much thyroid hormone, so your TSH is slowing down, decreasing, and then the T4 and T3 are going to be increased. You also may want to get your antibodies, your TSH receptor antibodies. In this case, it's the TSIs, which is the thyroid stimulating immunoglobulins, and that's something that you may see on the diagnosis. As far as treatment, there's a few different ways. The most common treatment that the boards want you to know, this is not necessarily true in real life, but as far as the boards are concerned, they want you to know that radioactive iodine ablation is the most common treatment. And this is basically ablating the thyroid, pretty much shutting it down and turning this patient into a hypothyroid state, and then treating with Synthroid. I know when I was in school, I always wondered why they can't ablate it to a point to kind of get a patient into a euthyroid state. Why always ablate them into this hypothyroid state and having to treat them? Well, it turns out years of research that they would try to do that just to ablate enough of the thyroid to get them into a euthyroid state, but in almost every single one of the cases, the patient eventually would transition into a hypothyroid state. So it was something that just wasn't worth the effort, and they always wound up going into hypothyroid. So this is one of the more common treatments that they want you to know. In clinicals, you'll see this a lot more, methimazole. Not too much PTU, but this is just an oral medication you can take that blocks the synthesis of new T4 and T3 production. PTU is a little bit more potent, and it actually blocks conversion of T4 to T3, but we don't use PTU that much in practice because it actually has a black box warning of hepatotoxicity. It's a much more dangerous medication than methimazole, which is pretty well tolerated, but you do need to monitor, do serial monitoring of the liver enzymes for these patients on either one of these meds. So that's important. PTU, remember that you're going to use this in a pregnant patient if they needed to be treated for Graves. You can use PTU in the first trimester of pregnancy, and then the second and third trimester you're actually going to switch over to methimazole. So PTU in the first trimester, methimazole for the second and the third. Methimazole is actually teratogenic in the first trimester, but so that's why you use PTU and then methimazole after that. You may also treat these patients with beta blockers. Propranolol in particular is a pretty common one. And this is just to decrease some of the effects that they're having, the adrenergic effects like tachycardia, tremor, AFib, just to make them more comfortable overall. As far as the ophthalmopathy, the exophthalmos and things like that, you know, generally we used to treat them with steroids, and that's what you're going to have on your boards because there is an FDA approved medication, but it was just approved as of 2020. So this is brand new. It won't be on your boards probably for a couple of years because they don't normally add these newer things for at least a couple of years, or 2 to 3 years. So for now, I would just know steroids for the ophthalmopathy, but there is actually a medication. So just kind of put that in the back of your mind, but don't worry about that too much for the exams. So moving on, we're going to move on to the extreme form of Graves' disease, of hyperthyroidism, and that's something known as thyrotoxic crisis or thyroid storm. So this is going to occur in a patient who's either not taking their medication, or they're taking some of the methimazole. They're just not treating it well enough, and then all of a sudden they have this really stressful event. They have a surgery, they have an MI, they have some kind of trauma, infection, something really stressful happened in an untreated or partially treated hyperthyroid patient, and then they go into this thyroid storm. So how is this patient going to present? They're going to present in a hypermetabolic state. They're going to have a fever. They're going to be tachycardic. They're going to have CNS dysfunction. They're going to have AFib. They're going to be really sick, and there's actually a really high mortality rate with this. So how are you going to diagnose this? Well, it's pretty straightforward. You're going to get the same labs that you would for hyperthyroidism. So you're going to have decreased TSH. Often it's zero. You don't see it at all. It's completely undetectable because the T4 and the T3 is so high. But that's how you test for that. Treatment. The four things I want you to remember, because there's a few things that I'll go over just so you have a completely like a complete view. But the four things I want you to remember for treatment, the most important things, is IV fluids, beta blockers like propranolol, PTU, and PTU over methimazole, because PTU, if you remember, we talked about before, not only stops the production of T4, T3, but it also stops the conversion from T4 into the active form T3. So it's the more potent medication. Again, these patients are really sick, high mortality rate. You want to use the best medication you have. Even though it has the higher side effect profile, it doesn't matter. These patients could potentially die. So you're going to use PTU, and then glucocorticoids. And you use glucocorticoids because they actually, just like PTU, decrease the conversion of T4 to T3. So those are the main things I want you to know for this: fluids, beta blockers, PTU, steroids. And then there's a couple other things you can do as well. Mostly things just to make them more comfortable. You can give them cooling blankets. You can give them antipyretics. And the antipyretics, you can use NSAIDs, things like that, but you want to avoid aspirin. And the reason you avoid aspirin is because aspirin actually displaces the thyroid hormone from thyroid binding globulin. So you have all of this thyroid hormone that's comfortably seated on the thyroid binding globulin. It's not activated. It's not, in the actual serum. Then as soon as you take aspirin, it actually pops off of there and goes into the free form, where it can be harmful to the body. So just important side note to remember: don't give them aspirin. Other antipyretics are okay. And you can also give them, after the IV fluids, you can switch them over to oral sodium iodine or IV iodide, which actually blocks the release of T4. So that's something else you can give them as well. But again, don't kill yourself. Just remember fluids, beta blockers, PTU, and steroids. So moving on to the opposite end of the spectrum, myxedema coma. So this is an extreme form of hypothyroidism. So in a vignette, and possibly in real life, the patients you're going to be looking for in these situations are normally elderly women in winter months. So this is because older women have, especially in obviously winter months and cold, have decreased thermal regulation, and if they're already hypothyroid, they have issues with this to begin with, and the hypothyroid can be exacerbated and turned into a myxedema coma. So vignettes, look out for that. Elderly women in winter months. Again, in a vignette, they normally don't mention something unless it's important. So if you see winter months, think about why they mentioned that, and it'll help you a lot of times to get your differentials down. So they're also going to have an acute precipitating factor, just like in thyroid storm. So maybe a CVA infection, non-compliance with their medication regimen, but something that's going to cause this. As far as the diagnosis, again, just like in your hypothyroid patients, you're going to have an increased TSH with a decreased T4, T3. Sometimes this TSH can be as high as like 150. These patients have a really high T4, T3, so their TSH, really low T4, T3, so their TSH is going to be extremely high, trying to compensate for that. So just remember that. And then as far as treatment, it's pretty straightforward. There's not a lot to know here. It's pretty much just IV levothyroxine, which is going to be replacing the thyroid hormones that they don't have. There's also some supportive measures to like passive warming, IV fluids, and things like that. So those are the important things you should know for those two. I don't think there's too much else they can ask you about that. So now just moving on to a few other topics that I wanted to touch on that I think are important. I'm going to bring up two different cases of different thyroiditis that are the only two painful causes of thyroid. So if you ever seen a vignette, their thyroid is painful, you should only be thinking of two things. You should be thinking of suppurative thyroiditis or subacute thyroiditis, which is also known as de Quervain or granulomatose. So remember, painful, only think of those two. So suppurative thyroiditis is going to be an infection of the thyroid gland, and it's either going to be from a gram-positive or gram-negative organism. The most common cause overall is going to be Staph aureus. Patients are going to be presenting, again, painful thyroid. Remember that. And they also are going to have other symptoms of this bacterial infection that they have: fever, chills, overall malaise. So not too specific, but remember that. As far as diagnosing these patients, they may have increased white blood cells, leukocytosis. Their ESRs may be increased, really non-specific, but just from that inflammatory process. And then the main thing here is you want to get an FNA to actually culture and diagnose the type of organism. And this is going to help you differentiate it from the other cause of painful. And then remember too that these patients normally have normal thyroid function. The thyroid's still functioning okay. There is an infection present, but the thyroid function labs are normally within normal range. These are normally euthyroid patients. As far as treatment, again, just thyroid function usually normal. As far as treatment, it's pretty straightforward. You're going to give them antibiotics. After you get your culture back and see what it's sensitive to, go ahead and treat them accordingly. And if there is an abscess present, there's a fluctuant mass, you can go ahead and do an IND. You can drain it. So pretty straightforward with that. And then moving on to the only other cause of painful thyroid is something called subacute thyroiditis, also known as Decorative vein or granulomatose. As far as the patho behind this, it's generally idiopathic, but in real life and in a vignette, it may follow a viral infection. So they may have had an upper respiratory infection last week, and now all of a sudden their neck is hurting and they're having all this pain. So remember that normally there's not a specific cause that we know of, but it does often follow a viral infection. And then as far as the labs, unlike suppurative thyroiditis that the patient was euthyroid, these patients initially usually present in a hyperthyroid state. So that's very important. And they normally follow this pattern where initially they're going to be hyperthyroid, then they're going to go back to euthyroid, then hypothyroid, and then back to a euthyroid state. And most of these patients, about 95%, do return back to normal eventually, back to euthyroid. As far as the presentation, painful thyroid, remember that. And then it may be accompanied by some upper respiratory symptoms, remember the viral infection. Diagnosis, they may have an increased ESR. They may present with hyperthyroid labs if it's early on. And then a biopsy, unlike the culture that we saw in suppurative thyroiditis. In these patients, the biopsy is going to show multinucleated giant cells. So remember that. It's another way to differentiate between the two. And then treatment, it's straightforward. It's pretty much just supportive because most of these patients are going to return back to euthyroid, and this is going to clear on its own. So most patients don't require any further treatment. So not too much they can ask you here. Basically, just a few things that I think you should know for this. Moving on to two more things that I think you should know for thyroid, and really just a few things to know for these. So subclinical hypothyroidism is very straightforward. This is going to be an asymptomatic patient. They're going in, they're just having their general labs done for whatever reason. The primary care doctor got a TSH just to make sure that everything is okay with their thyroid. And then for some reason, they have this increased TSH. But the TSH is accompanied by normal T4 and T3. It's just the TSH that's elevated, which is important to remember. And then how do you treat these patients? Most of the time you don't. Most patients are going to resolve on their own in about 6 months, sometimes a little bit longer. Most patients will return to a euthyroid state. TSH will resolve and get back to normal. The only time you're going to treat these patients, and this is a little controversial, some sources state different suggestions, but generally the consensus is if their TSH is above 10, you may want to treat them with some low-dose levothyroxine just to avoid some of the cardiovascular complications. It's not really too much to know here. There's not much they can test you on. The main thing to remember is this is going to be an asymptomatic patient with an increased TSH. Last thing that I want to touch on that I feel like you should know, again, not too much to know here either, but euthyroid 6 syndrome, and it's all in the name. So euthyroid 6 syndrome. So this is going to be a really sick patient, really sick older patient with some precipitating event. The patho behind this is actually the illness is causing a decrease in the peripheral conversion of T4 to T3. So it's not the thyroid itself that has a problem. It's actually the conversion of the T4 that the thyroid is pumping out normal. These patients, again, are euthyroid, so they're not having an issue producing T4, but there's a problem because of the illness and the peripheral conversion of T4 to T3, which again is happening in the liver and other peripheral tissues. So what are you going to see here? The way I remember this is euthyroid starts with an E. You flip the E backwards. What do you have? A 3. So I always remember euthyroid 6 syndrome is decreased T3. And I just always remember euthyroid starts with an E. Flip it backwards. You have a 3. That's really the only thing you need to remember here, because the TSH may be normal. Everything else is probably going to be normal. Really just need to know that they have a decreased T3 because they're very sick. Treatment, treat the underlying cause. If they have some kind of infection, an MI, sepsis, malignancy, whatever it is, just treat the underlying cause. Not much to know here. This is very straightforward. Just remember that there's a decreased T3, and there's really not too much else they can you on. So that's it. I hope this was helpful for you guys. The only other thing I want to mention is that I also have a podcast under the same name, Cram the Pants. If you want to check that out on Apple Podcasts, Spotify, it's on all of those. Just a more condensed form of what we went over here without the visual aid for when you're driving down to your clinicals and things like that. So thank you again. I'm going to be coming out with more videos. Please subscribe, like my videos, let me know what you think, and good luck in PA school.